My dear learned audience, Assalamu alaikum. So today my presentation, gel balloon technique is coronary bifurcation lesion by radial route. Bifurcation lesion accounts for approximately 15 to 20% of all percutaneous coronary interventions. Current studies shows the benefit of simple stenting approach for simple bifurcation lesion. And here the side branch preservation is an important issue. Side branch mechanism of side branch deterioration is by plex shift and carina shift. So this is, we all know, this is the management strategy of bifurcation lesion. So my topic, strategies for protecting the side branch during bifurcation lesion PCI in case of provisional stent strategy. Provisional, there might be provisional double stent and double stent primarily from double stent strategy. So provisional stent strategy can be done with gel wire technique, gel balloon technique, modified gel balloon technique. There are other techniques as well. Side branch occlusion may be a disaster during coronary bifurcation intervention and leads to serious advanced clinical events. Protecting the side branch to keep it open is one of the main principles when performing bifurcation lesion intervention. Provisional stenting using a gel side wire is most extensively accepted simple technique, but a gel wire is unable to prevent side branch closure after stenting of main branch. So gel balloon technique is considered to be the more effective in preservation of side branch patency. So this is the COBIS registry. They have shown the superiority of the side branch protection by gel wire technique than the single stent technique. This is the couple of literature for gel balloon technique. Journal of American College of Cardiology, then Journal Intervention Cardiol, then Euro Intervention Journal, then Euro Intervention Journal. They all shows the superiority of gel balloon technique over the gel wire technique. And this is the literature published in 2022. Just this year, they have shown the gel balloon technique is superior to the gel wire technique in reduction of rate of side branch occlusion. And this is the one, BMG, this is the large study, CIT resolved trial. They have also shown the superiority of gel balloon technique over the gel wire technique in provisional stenting bifurcation lesion. This is also from China, Tanjim Medical Journal. So they have shown, they have done 12 months follow-up. They have shown that MACE is lower in gel balloon group than the gel wire group. So two types of gel balloon technique, as I mentioned, conventional gel balloon and modified gel balloon. So this is the difference I have collected from different literatures. The main difference in conventional gel balloon and modified gel balloon technique. So in both, the starting is the same. You wear the main branch and the side branch, and main branch is pre-dilated and as necessary the side branch. And in case of conventional gel balloon, balloon is that the size to approximate the side branch vessels and diameter generally 1.5 to 2 millimeter and with adequate length. And the proximal marker of the side branch balloon positioned approximately 0 to 2 millimeter proximal to the stent. So this is the one conventional gel balloon technique. And in case of modified gel balloon technique, the side branch is uniformly decided to be the half of the planned main branch stent diameter. And position of the gel balloon is carefully adjusted as its proximal end is attached to the main branch stent. So this is the one. After that, the main branch stent is deployed in conventional gel balloon and the keeping the side wire and the balloon gelled. If the side branch has not been compromised, then the gel balloon is the side branch balloon is inflated to a low pressure, that is up to 6 ATM. But in case of modified gel balloon technique, the main branch stent is deployed. Both the stent and the gel balloon are simultaneously inflated at the same pressure, normally at 12 atmosphere. After that, it is similar that next the conventional gel balloon and modified gel balloon, the next steps are almost similar. So we won't go to that. So this is, in our lab, we have used 6 French guide catheters and 7 French guide catheters. For 7 French, we have used the slender guide sheath, 7 and 6. And we took the 7 French guide catheter, we have tracked it by the Kumar technique. Now see, let's see a couple of cases. So here is a direct stenting. The side branch D1 looks, ostia looks healthy, so during PCI to LED no protection is needed. So this is the stenting, direct stenting done. Another one, a young man with STMI here, it's a direct stenting. It was done without keeping a gel wear in the side branch, and after that the large diagonal is lost after the main branch stenting. Now comes the gel wear technique. So here, significant stenosis in the LCX and OM, provisional stenting done with a gel wear in the side branch. But the result was not that much appreciated, so side branch was dilated again and then FKBI done, and this is the final result. So this is the gel wear technique. Now comes the gel balloon technique. So here large D1 branched and main branch stenting with gel balloon, and main branch is stented with a gel balloon in the side branch. So this is after pot, this is the final result. So this is an LM to LED crossover tent. Here there was LM, LED and LCX Medina 110 bifurcation lesion, but there was 111 lesion with LM to D1, LED to D1. So deployment of the stent from LM to LED was done, but keeping a gel balloon in D1. So this is the final result. Now come the gel balloon technique again, the LED D1 bifurcation lesion, it was post PCI to LED. This patient came with unstable angina. After we done the angiogram, there was the pattern stent was in situ, but after the stent there was LED and D1 bifurcation lesion. So stent was placed in the main branch, keeping a gel balloon, the side branch, post dilatation done. But result was not that good. We did the KBI, FKBI, and this is the final result. Another modified gel balloon technique, here there was CTO and the lesion in the LED. Lesion was crossed with microcatheter. And then pre-dilatation, after the pre-dilatation, there was a big diagonal 111 Medina. So this is the gel, main branch was stented with a gel balloon in the side branch. Then post-dilatation done, and this is the final result. Another one, there was a significant stenosis in the RCA proximal, and there is a bifurcation lesion, stenosis in PLB and PDA. So stenting done, RCA to PLB with gel balloon in PDA. And then proximal part stented, and this is the final result. So gel balloon technique, so a series of complicated technique to preserve the side branch. What are the realistic advantages? Yet to know. Does it really prevent the side branch occlusion? Is rewiring and kissing balloon needed? So yet to be answered. So there are some experience in our Bangladesh experience. It was done under the guidance of Professor Mir Jamal Uddin since 2017. We done 119 cases, mostly LED D1, LCX, OM, and RCA, PDA, PLB. almost all done by transradial approach. And procedural success was 100%. So take home message, the new gel and modified gel balloon technique provides maximum SB protection in cases of bifurcation lesion. It requires less time, reduces side branch occlusion risk, even though side branch balloon was inflated. The immediate clinical outcome and procedural success will encourage to use the technique safely and reliable preservation of side branch patency. So thank you.